So good afternoon, everyone. I'm really thrilled to present to you this basics and some essentials about gonioscopy, and I'd like to welcome all the audience here at the weekly Grand Round subspecialty lecture. I'm Dania Bamefleh. I'm one of the members of glaucoma division, recently graduate at KCASH. Today our talk is going to be about gonioscopy and how important and essential part of eye evaluation it is. The outline of the lecture today is to go through the history of the gonioscopy, the principles of the examination, the indications and the contraindications, possible methods to evaluate the angle, and go through the normal anatomy structure of the angle, and we'll pass through the grading system, and we will have some examples of abnormal angles, and lastly a short summary about gonioscopy. So in history, gonioscopy was first discovered by the Greek ophthalmologist Dr. Alexis Trantis, who discovered the angle could actually be visualized in a patient that was having a severe steepening of the angle in a patient in an eye that was a keratoglobus, and he was only able to evaluate the angle while indenting the sclera along with his finger, and this was back in 1907. And this photo actually was awarded back in the RSOS conference in 2019, and credits to all my colleagues. So why do we do gonioscopy? What is the aim of it? It's a very essential part of the comprehensive eye examination, and the omission of utilizing this tool could actually lead to misdiagnosis, and should be done initially at all glaucoma patients and also for suspects, and should be repeated periodically in all cases, especially in those with a narrow or a closed angle. So what are we looking for in performing the test? We are looking for the angle landmarks, looking for the level of iris insertion, the shape and the profile of the peripheral iris, the estimated angle width, and the degree of trabecular meshwork pigmentation, the confirming the presence or absence of any apposition or synechial closure. Defining the angle is the area that is between the anterior surface of the iris and the posterior surface of the corneal layer. To visualize this critical junction, it's not possible to the naked eye due to a shallow angle is being reflected, and therefore this image will be totally internally reflected back to the eye. To overcome this, and due to the physiological aspects of the gonioscopy, shields were suggesting that this can be overcome by using contact lenses back in 1992. So we use a contact lens in order to overcome that, and therefore I'll be able as an examiner to evaluate the angle and see through the entire space there. Methods of performing gonioscopy, it can be done direct or indirect ways. The direct evaluation, we have certain lenses for that, and maybe you will find us more utilizing it in OR rather than in OPS services. For the Kopay lenses, for example, we have a 15 millimeter diameter, and we have an 18 for adults. With the aid of a handheld biomicroscope along at a position that is supine, requires a supine position, and a magnification between 15 to 20 times is usually attained from those lenses. The advantages of doing direct gonioscopy, you would be able to visualize the angle straight on the view. what you are seeing is there. It's not a mirror image, and usually it's panoramic view. The disadvantage is it's not convenient and usually requires special tools to be done and special positioning also. Other examples of the direct lenses we have in OR is the Swan Jacob. We have the, I think it's made of the stainless steel rather than the silicone like this picture. And we have the old generation Huskin bark and contact lenses. The indirect gonioscopy, it can be performed either with a suction type or a non-suction type. For a beginner, I would advise to start with a suction type. The suction type, it usually utilizes a viscous-like fluid between the eye and the contact lens, and it usually gives a better quality images for beginners. The non-suction type, it's rapid evaluation. It gives less quality of images. However, it's maybe more convenient and widely available. But the other thing, or the downside of it, that too much pressure can give false impression. These are examples of the indirect gonio lenses we have. We have a 4-mirror, 3-mirror, and 2-mirror. And nowadays we use the 6-mirror more often, you will find it. So what are the indications to perform gonioscopy? Any observed narrow angle, history of an angle closure attack, history or suggestive history of a trauma or an ocular foreign body, active or past inflammation in the anterior chamber, evidence of neoplastic activity in the chamber, and the possibility of a new vascularization. What about the contraindications to perform gonioscopy? Needless to say, in cases of questionable integrity of the globe, and in cases of fresh hyphema, and also in cases of an active infections like herpes simplex or epidemic keratoconjunctivitis, and in cases of very fragile thin epithelial basement membrane dystrophies. So how do we perform gonioscopy? My advice is to start by explaining yourself to the patient and explain the procedure. And it's usually a pain-free experience and does not require more than a couple of minutes. So we start by applying a local anesthetic, and then we have to pay attention to the patient's comfort, and the alignment of the light of the microscope can be swept to the right and to the left if you're evaluating, depending is it nasal or temporal side. And it's better off to be done at a dark room, but pay attention not to shine the light directly to the pupil, otherwise you might falsely open the angle and cause constriction of the pupil. And the etiquette of using it is the examiner should be using the right hand to evaluate left eye and the left hand to evaluate right eye, and use suitable lenses, whatever you feel comfortable with. As a beginner, my advice again to start with the 3-mirror lenses. Disinfect the lens, of course, prior and after every use. The slit lamp settings, it's important to utilize a magnification either 10 to 25 magnification and not to go beyond that, because otherwise the images will not be very clear. To use a short and narrow beam, and as I told you, you can move the light source right and left to evaluate nasal and temporal, and focus the light on a D-shaped mirror in cases of a 3-mirror Goldman. Avoid throwing the light, as we said, too much to the pupil, and use magnification if needed for finer details. Pay attention that when you are doing or performing an indirect gonioscopy, what you are seeing here, for example, at 6 o'clock, it's going to be upside down. So you will see it here at superior D-shaped mirror. But whatever you are seeing nasal is still nasal to that, and whatever you're seeing temporal is still temporal to that. So it's not laterally reversed, unlike cases of indirect ophthalmoscopy, which has different physiology. So in Goldman, again, we utilize the D-shaped mirror for visualizing the angle and others as in the pictures shown. The main advantages of doing indirect gonioscopy, it's a quick, it's convenient, and no special equipment much is needed, and it allows the differentiation of a positional and synechial angle closure because of the advantage of performing dynamic gonioscopy. The disadvantages of that is that mirror images, sometimes it's confusing for a beginner. Inadequate or too much pressure on the cornea could give actually false impressions, like too much pressure, for example, in cases of a 3 mirror, can narrow the angle falsely, or too much pressure in a 4 mirror use, it can falsely open the angle. So it's very important to pay attention to some of factors that could actually be also an obstacle. Patient factors, pupil size, the lens status of the patient's cooperation. It's very important, and it can be also based on the observer, like air bubbles getting trapped between the lens and the cornea, or too much pressure is applied on the cornea, unstable hands, improper focusing of the images, or even the lack of experience. So let's get to the normal anatomy and normal angle structure. So what are we seeing is usually we evaluate the iris as seen here, and therefore after that we have anterior to that we have the ciliary body face, followed by the scleral spur, which is the area of attachment of the longitudinal muscle of the ciliary body. And after that, we have the trabecular meshwork, the two parts, the pigmented and the non-pigmented. And the most anterior part of the angle is the Schwalbe's line. So the iris, it's very important to pay attention to the iris. Like sometimes in high myope people, you will see that it's usually giving the concavity shape, and hyperope, it's usually convex, and also in people that are having a pupillary block, you will see the abnormal convexity there. And in cases of pigment dispersion syndrome, you will be able to see how deep and concave the peripheral iris is, because it's a reverse pupillary block syndrome. Abnormal or double hump sign, as in cases of plateau iris, as seen in this second figure. Evaluating the ciliary body band is also very important, because it's it's being there, it means that the angle is widely open, but you have to also pay attention for signs of previous traumas or injury or iatrogenic injuries, for example, like the cyclodialysis or angle recessions. The scleral spur, its obscuration on the view can be also by any of these. It can be due to narrow angle for sure, but it also can be due to iris prosthesis overlapping it, iris bombae, peripheral anterior synechia, and some pigments could be there as well. Paying attention to the pigmentation and the visualization of trabecular meshwork is very essential as well. Schwalbe's line, which is the terminal part of the Descemet's membrane. It's very important, and sometimes being seen too much, as in cases of pigmentary glaucoma, or in cases of pseudoexfoliation or previous uveitic attacks, forming a Sampoliz's line. The different grading systems for the angle, we have the Shea system, which is usually meant for evaluating the most posterior structure visible, and this is therefore the grading system between 1 to 4. And the Schaffer, it's exactly the opposite, and it's usually assists the geometric angle width in 4 grades, and the angle, and studies the angle potential for occludability. The SPATH system, which is a 3D system, because it studied multiple things, not only the angle width. It studies the level of insertion of the iris roots, the width of the angle, the configuration of peripheral iris, and the posterior trabecular meshwork pigmentations. So the first part of the evaluation is the level of iris root insertion. It can be divided between A up to the E level. A is anterior to the Schwalbe's line and B being behind the Schwalbe's. C is on the scleral spur. D is behind the scleral spur and E is on the ciliary band. Evaluating the width of the angle, it can be divided further to narrow 10 and 20 or wide 30 to 40 and even beyond in some cases. The configuration of peripheral iris is also very important to pay attention to. Is it steep, like in cases of too much convexity, or is it regular, or is it queer, the opposite? Pigmentation evaluation of the trabecular meshwork is also very important. You can grade it from 0 up to 4, which is heavily pigmented trabecular meshwork. The differential of that could be in cases of pigment dispersion, pseudoexfoliation, traumatic or uveitic cases. Now, coming to performing dynamic indentation gonioscopy, the gist behind it, or why we are doing this is actually to distinguish between a positionally closed angle and synically closed angle. Because usually in a positionally closed angle, you can overcome it by applying a light pressure on the central part of the cornea. By using the lens itself, you will be able to reopen it, but you will not be able to in cases of peripheral anterior synechiae. This is the Shea system. As we said, it's grading from between 1 to 4, and 0 is even like slit or completely closed. The Schaffer system, again, it's a 4 grading system, and it's due to the occludability of the angle. So 0 is being narrow and 4 is the widely open one. And you can use whatever system you feel like. The Van Herrick is also maybe more convenient evaluation in cases of, or in days that are very busy, because its utilization is very simple and can be done like almost daily. The width of the AC, and you have to shine the narrow slit beam, that the one that falls on the cornea and the second one that's falling on the iris, and you put your light beam like you keep it at 60 degrees away from the light, and therefore you will be able to judge the depth of the AC. The depth of the AC can be also divided in grading system. Grade 1, that is less than 1/4 of the corneal thickness. Grade 2 is almost equal to 1/4. Grade 3 is half the corneal thickness, and grade 4 is exactly like the similar to the corneal thickness or even beyond that. This algorithm, I find it very interesting, and it actually simplifies the evaluation. So if all structures are seen and their incorrect anatomy is preserved, then if yes, then look for the trabecular meshwork pigmentation level. If it's normal, then this could be a primary open angle. If it's abnormal, then look for the heterogeneity of the pigmentation. Is it like heterogeneous, then it's most likely exfoliative syndrome. If it's more of a homogeneous, or like all over the angle it's pigmented, this is most likely could be pigment dispersion. These are not exclusive, but these are to help you to evaluate the angle better. If the structures were not normal, or there was like something abnormal with it, then it has to be like one of these 3. Is it poorly differentiated, or the iris seems to be an anteriorly inserted? This could be a congenital, like in cases of congenital glaucoma or juvenile glaucoma. It can be angle recession, like you can see the ciliary body is too much seen and the scleral spur is very widely glistening, then this could be post-traumatic injuries. Or it can be, as in cases of posterior synechial formation or membranes due to uveitic or neovascular diseases, or also in cases of ICE syndrome, which is iridocorneal endothelial syndrome. So what other abnormalities can be seen in an angle? You could look also for peripheral antisynechiae, neovascular vascularization, signs of any trauma, tumors, and also sometimes you are able to diagnose some diseases just from looking through the angle. We'll see a few examples. And also in cases of foreign bodies and early detection of Wilson disease as in Kaiser-Fleischer ring. This is an example of a patient that's suffering from neurological impairment, and the patient has Wilson syndrome. And you are here able to see that the copper deposition at the most anterior part of the angle, that is the Schwalbe's line. The silicone oil here, you can see some droplets are seen here in the angle structure, and usually it travels superiorly. Some other examples, you are able here to see the iris pigmentation, and this turns out to be an iris melanoma after investigating the patient and evaluating him. And this is an example of the haptic of the IOL being seen here against the angle, and this for sure requires repositioning of the IOL. Other examples, we have iris prosthesis. Iris prosthesis are different from peripheral anterior synechia because they are usually fine, and you can see the sclerosphere in between them. Unlike the peripheral anterior synechia, you will not be able to see the sclerosphere. It would be obscured, and it's usually broad, and usually it has an underlying etiology. Iris prosthesis, which are majority of the time, they are harmless. Another example of PAS or peripheral anterior synechia is being seen here. And some example of new vessels are seen here in the angle of the eye due to different pathologies. And here also an example of a new vascularization of the angle due to ischemic retinal changes. And this individual had an ocular trauma 20 years ago, and then he developed a refractory glaucoma. And here you can see that the angle is recessed, and actually this is the normal angle anatomy. This is a PAS, but here is a normal angle anatomy, so you can evaluate both at the same time. It's very essential to do, whenever you have an angle recession, it's very important to do evaluation at 360 on this eye and another evaluation for the fellow eye for comparison. This is an example of a foreign body being found in the angle after many years of trauma to the eye. Evaluating the angle is also very important in some diseases, and can be also helping in the narrowing down the differential. Like this patient with stellate keratotic precipitates with a picture of an anterior uveitis, and you can see some fine fragile blood vessels here and there with the absence of synechial closure. And this is an apsilar sign, and with too much pressure you can even see a light like a hyphema, or like blood is coming out from the angle. Pseudo-exfoliation, and this is the Sampolizi's line. You can see there, and the trabecular meshwork is heavily pigmented, but it's heterogeneous, unlike the cases of pigment dispersion. Along with that, in pigment dispersion, you can see that the iris seems very concave in shape as well in a high myope individual. So in summary, the gonioscopy is an essential part for the comprehensive eye exam, and choosing a proper classification to evaluate the angle properly to reach to a diagnosis. And the gonioscopy is very much an acquired art, and the optimal utilization requires considerable personal experience and a lot of patience. The awareness of the sources of errors and the proper interpretation of finding results in a shorter learning curve. And proper long-term management of glaucoma requires a thorough gonioscopy at appropriate intervals, because the condition can actually change and the angle can change. It's not static throughout life. And also I have a video for gonioscopy if you guys you still have time if you want. Otherwise, we are done. There you go.
Between the peripheral cornea, corneoscleral junction and peripheral trabecular meshwork with the very peripheral iris. So the main principles: minimum light, minimum distortion, and minimum discomfort, because you would like your patient to come back. So we need adequate anesthesia, a narrow beam. We need to identify the corneoscleral wedge, and we're doing it in the dark. So adequate anesthesia is the most important thing. Generally, I use proximeticaine and then something else. So oxybuprocaine or tetracaine. Look up to the ceiling, please. The reason we try and minimize the amount of light falling on the eye and have the room lights down is all about maximizing the chances of detecting angle closure. Nothing else. You can see everything you want to see with the lights on. But if you're trying to look for angle closure, you want the pupil to be in its natural, resting, closest to mid-dilated state as you can. And that's really the only reason for turning the lights off. But there's very good evidence that if you leave the lights on, you'll miss a lot of angle closure because the angle can change so readily. For looking at the front of the eye, I always try and have a look first. So just do a simple Van Herrick type limbal anterior chamber depth assessment with a relatively short beam and a very, very narrow bright beam. So taking the gonioscope with lots of whatever coupling fluid you're using, it wants to be something that stays there if you turn the lens upside down. If it's too liquid, it will just drop off and it'll make life awkward. The lamp housing for the top and bottom angles is angulated off to one side with a vertical beam. And if you don't do that, you will not be looking onto the light from the side. You'll be looking at it from straight on. So there are then different ways of inserting the lens, and no way is necessarily better than the other. But what I tend to do is use my ring finger to hold the lower lid, ask them to look up, angulate the lens towards the eye, and then here I've got the angulated beam, and you're looking for the beam from the side on. And then what you see is basically brown iris and then white sclera above it. And sometimes you see some brown lines along that. What you are trying to find is the corneal wedge. And that is the outermost peripheral point of the cornea. And that's the point at which the cornea is turning into sclera, and that is Schwalbe's line. And the reason that's important is that Schwalbe's line is the anterior most extent of trabecular meshwork. That is the sort of picture that you get. It's blurred, it's not obvious to start with. If you just use brown stripes to identify your landmarks, you can get confused because the brown stripes can be very, very different. Often you get pigment in front of Schwalbe's line, then you get anterior trabecular meshwork, then you get posterior pigmented trabecular meshwork, and then you come back down into the iris, sometimes sitting on the ciliary body face. So what you see is a series of brown stripes, and what you need the corneoscleral wedge to do is identify which of those brown stripes are which. You're trying to generate a picture like that, which is a narrow, off to one side, narrowed, very, very thin but bright beam, shortened because you don't want too much extraneous light, endothelium, epithelium coming down to join in a wedge there, defining where Schwalbe's line is, and then everything beyond that is trabecular meshwork leading down to scleral spur. And it can be a number of different shapes, but it's that sort of blunt edge. Sometimes it's very pointy, sometimes it's round edged. That's very, very thin, thinning it right the way down to get that sort of wedge-shaped structure there. You can see there are lots of brown stripes down here, which are very confusing as to what they might be. If you have a broad beam, you can see the angle nicely, but you can't see that corneoscleral wedge landmark. Whereas when we start off, thinning it right the way down, that's telling me that, so that line across here is going to be Schwalbe's line, and in front of it is trabecular meshwork.
So thank you guys for attending, and if you have any questions, we have all the time.
Thank you very much, Dr. Dania, for this very concise and comprehensive overview of the gonioscopy. So I think it's very crucial for all ophthalmologists, not only glaucoma specialists, to master the gonioscopy, because I believe it is very important to direct every ophthalmologist to what is exactly the diagnosis. So if you have a correct diagnosis, for sure you will manage the patient properly. Especially nowadays, we have lots of mixed options on table, and it's very important to have an good or good gonioscopy. Management or gonioscopy examination. So thank you very much for this overview, and good luck.
Thank you, Dr. Bishri. Thank you. You have any other comments or questions? Mm. So, have to thank you all for attending, and I wish that I added something to you with this overview. And good luck